I guess it's time to start. Hello, everyone, and welcome to the RX Hope Table Talk session number 3, titled Movement Disorders in SCN2A. It's not a seizure, but it is treatable. This session is being recorded right now. My name is Mary Ullman, and we're very excited to be bringing this virtual educational experience to our global community. During these sessions, the families and caregivers of the patients with SCN2A related disorders will be referred to as the experts, and the presenters will be the professionals. The goal of the virtual table talks is to allow experts unprecedented access to professional researchers and clinicians working diligently to find a cure for our children. This is meant to be a very casual environment, and your questions and comments are highly encouraged as we are all here to learn from one another. To keep things running smoothly, please keep your audio on mute and use the reactions button to raise your hand if you'd like to talk. Alternatively, you can send questions through the chat. And if you haven't already, please introduce yourself and your SCN2A child in the chat. Perhaps their name, their age, how SCN2A presents, for example, autism versus epilepsy or both, or something else, and where you live. I now have the pleasure to hand this over to Dr. Keith Coffman from Children's Mercy in Kansas, Missouri, and Jennifer MacLean, nurse practitioner from Children's Hospital, Orange County. They're movement disorder specialists who have taken their time to share with us today. So thank you and welcome.
Okay, and I think I'm leading first. Is that what we are leading? Okay, let me share screen. Oh, host has disabled screen sharing.
You're good now.
Okay. Okay, does everybody see the opening slide?
Nope.
What do you see?
You.
Okay. There we go. I told you I was not a Zoom pro.
There you go. You were cutting off.
Okay. Okay. So as I was putting this together and realizing how little we know about what
we may have lost Dr. Coffman. We'll give him 1 minute to see if he pops back on. Jennifer, are you able to start? If not able to reestablish connection soon?
Yeah, I can go ahead and start off. It'll be a little out of order, but I think that should be fine.
Okay. Yeah, to give it a go.
Okay, let me see if I then can get my screen to start sharing.
Yeah, Zoom keeps kicking me out of the meeting. I don't know what's happening, but it keeps kicking me out of the meeting.
Dr. Coffman, in the past, I've had to look if I call in for the audio and then just screen share to share the presentation, if you want to try that.
Well, let me stop my video. And can you re-enable screen sharing? Because it's telling me again it's disabled. Okay, are we in business?
Yes.
Okay, so we're talking about tic, then myoclonus, then tremor, then chorea, and then bolismus, dyskinesia, dystonia, and spasticity. Okay, so some general principles. Hyperkinetic movement disorders, so involuntary movement disorders, arise from problems within the basal ganglia. So the basal ganglia are the brakes of the brain that help to generate and inhibit movement. When the basal ganglia don't work properly or malfunction, extra involuntary movements can show up. Here is a very simplified wiring diagram of the basal ganglia. And I say simplified because this is just a schematic from one of the best neuroanatomy textbooks. And when you look from the top down, it shows the cortex, so the surface of the brain. And then all of the structures in blue are the basal ganglia. And they have a bunch of different names. Starting at the top center, you see the striatum. It's called that because when you look at it on MRI or under a microscope, it is striped. And then down below, you see GP, you see GPE, GPI, and that's the globus pallidus. It's called such because under the microscope, it is a white ball. And then below that, you see SNR. So the SNR is substantia nigra, which literally stands for black substance. So neuroanatomists are not creative people. They describe things based on how they look or where they're located. Okay. So a hyperkinetic involuntary movement disorder is where you have the inability to control voluntary movements due to the presence of extra or unwanted movements. Spasticity, which we'll talk about later, is not a movement disorder per se. It's an abnormality of muscle tone. Dystonia is an abnormal movement, and we'll talk about that one as well. We'll first start off with tic. So tics are sudden, what we call stereotyped, meaning they look or sound the same every time they occur, non-rhythmic movement or vocalization. So it is the most common pediatric onset movement disorder. Tics occur at a rate of about 1 per 100 people at minimum. Tics can be painful, but they most often don't interfere with quality of life. And when you think about a tic can be something as simple as an eye blink or a throat clearing or a shoulder shrugging. What happens with tic is you get a just sort of brief muscle contraction that really looks like a movement that's supposed to be there, like an eye blink or a clearing your throat or a sniff, but it doesn't fit the context, okay? The child may sniff even though he or she is not congested or have an illness. He may blink his or her eyes even though there's nothing in the eyes. And the key thing with tic is it looks the same moment by moment, day by day, month by month, okay? what typically happens with tic, and if you're suspicious for tic, what typically occurs is a patient who has a tic disorder will start with one movement or one sound, and then over time, he or she will accumulate a number of other movements and sounds as they go on. Okay. We'll next talk about what's called myoclonus. So many families who have children with epilepsy know myoclonus because you can have what are called myoclonic seizures. So myoclonus is a sudden lightning fast contraction of a muscle. So it's a really quick muscle jerk, often a single jerk in my world, as opposed to a myoclonic seizure, which can be repetitive jerking over and over. You can see myoclonus as a manifestation of epilepsy. So in patients who have myoclonus, you can see this leading to falling and dropping of objects. And it's the one movement disorder that consistently needs an EEG, because myoclonic seizures, as some of you may know, can be so brief that they occur just for a split second and then they're over, but the EEG shows an abnormality. So in my world and my practice, every time I see someone with myoclonus, I get an EEG to make sure it's not myoclonic seizures. Because of the nature of myoclonus, it's treated very much the same way as you would treat myoclonic seizures. You either use a benzodiazepine, so something like Ativan or Valium or clonazepam, or you use anticonvulsants. It's really the only movement disorder whose main treatment is exactly what you would do for seizure. So tremor, by definition, is when you have an alternating contraction of an agonist and antagonist muscle. So what's an agonist and what's an antagonist? One that moves the limb one way, one that moves the limb the other way. So if you're sitting there with your palm of your hand flat against the table and you take your thumb and rotate it up, you can see and feel that the muscles on the inner aspect of your arm are the ones tightening. The ones on the other side, along the outside of your arm, are the antagonist muscles. So when you think about a tremor, you can understand why tremor is shaky, because you've got one muscle group that contracts and another muscle group that contracts, and that's why it looks like a shake. With tremor, you can have tremor at rest. So you can have tremor when you're not moving at all. You can have tremor that happens with what's called actions, whenever you attempt to move. When it comes to tremor, I say it's the most heterogeneous movement disorder regarding cause, because so many things can cause tremor. Asthma medications can cause tremor, caffeine can cause tremor, anti-seizure medications can cause tremor. So trying to list the causes of tremor is really an exhaustive list. The key thing when you think about, is it tremor or is it something else, is the following. Tremor typically has a set frequency and a set amplitude, so it really looks the same no matter what position the body is in. So if it looks shaky, but it changes direction, changes speed every time your child moves, that's probably not tremor. It's probably something pretending to be tremor, and we'll talk about that. When we treat tremor, it's one of the treatments that we use is a medication called propranolol, which is also used to dial down output from the autonomic nervous system. And then the other two medications that we use to treat tremor are a medication called primidone, which is a very, very old medication that is broken down by the body into phenobarbital, which some of you may have heard of. And then a medication called gabapentin, which many of you know can treat seizures, can treat nerve pain, can treat irritability. The next movement disorder we're going to talk about is chorea. So chorea is derived from the Greek root word choros, meaning dance. And it's called chorea because what happens with chorea is you get contraction of an agonist muscle, so a muscle that, say, flexes a joint, and then disinhibition of the muscle on the other side, so the muscle that contracts the joint. So if you think about moving one part of your body and the other part not arguing, it's going to look flowing and dancing. And that's how chorea got its name, is because when you look at people who have it, it looks like they're dancing. Now, when you see a child, maybe a child who doesn't have great ability to say what's going on, this can be an exhausting problem. This can also be a really uncomfortable problem. So if you see your child who is looking nonstop fidgeting, like he or she can't get comfortable, and is having this sort of writhing type movement, that could be chorea, and he or she may not be able to say, hey, my body can't stop moving and I'm exhausted by it. The reason chorea can be challenging to treat is because for many of the things we use to treat chorea, not as many of them are anti-seizure medications as some of the other movement disorders. So we can use medications like lorazepam and diazepam, which are known in the United States as Ativan and Valium. We often use a medication called amantadine to treat chorea, which in no way, shape, or form treats seizures. There are some people that use valproic acid and oxcarbazepine. But one of the main medications used worldwide to treat chorea is a medication called tetrabenazine, which also has no anticonvulsant properties. So chorea may be a condition that requires somebody else besides your primary neurologist to treat, because it's a rare condition for most child neurologists. Okay. Now, Bolismus, if you think about Bolismus, think about the word ballistic, because they're the same root word. And Bolismus is a contraction of an agonist, so just like chorea, and the same disinhibition of the antagonist, so no competition when the other muscle moves. But what's different is it's a larger amplitude and much faster. So think like bullet-like fast. So what happens in Bolismus is you will have a rapid flailing type movement, very dramatic. And it can be understandably painful and absolutely exhausting to treat Bolismus. If you've ever seen someone with a Bolismus type movement, a rapid, dramatic type movement, it is an absolutely unforgettable image because it is so highly atypical compared to what any other movement would look like. Okay. And the treatment, we use the same kind of medications we use to treat chorea. In the world of movement disorders neurology, we have our wastebasket term. So our term for which we use for movements when they don't follow another pattern, okay? And that wastebasket term in our world is what's called dyskinesia. So a dyskinesia is a problem where you have a random, non-rhythmic movement that don't look like any of the other movement disorders we've talked about. So it doesn't fit into a box. Most people, when they think about dyskinesias, know that dyskinesias can occur with other movement disorders. The most common representation of dyskinesia is when you have movements of the mouth, lips, and tongue. And I'm going to see if my video holds up. So what we think of in the world of dyskinesias is this kind of movement. So you see really uncontrollable and that kind of movement. And that if you have that kind of movement about your lips, tongue, and mouth, oh, I think I froze again. Okay. It can be exhausting and interfere with movement, including things like eating, drinking, and swallowing. Okay. Now we'll talk briefly about spasticity. So spasticity arises when the brain and/or spinal cord signals to the muscles are disrupted. And what happens in spasticity is the muscles overcontract statically, so all the time, because of the fact that they don't have the appropriate inhibition. So signal to say, don't contract right now, okay? Spasticity, while not a movement disorder, it is a disorder of muscle tone, so the resting muscle activity is too high. What happens in spasticity can still be life-altering and problematic because it can be painful, it can lead to joint deformity, it can lead to disability. So while not a movement disorder, we in the world of movement disorders neurology treat patients with spasticity because we use the same things that we do to treat other problems. So we use the benzodiazepines, and we also use a medication called which here both from me as well as from Jennifer. And last on my list is a medication called, or is a condition called dystonia. So dystonia is where you have the concise exercises where your muscles nonstop. So dystonia is the most severe potentially of all the movement disorders, which is I saved it for last. On the planet, it's probably the third most common movement disorder overall. That you're basically contracting your muscles that both flex your joints and extend a joint nonstop. It can lead to muscle breakdown. It can lead to joint destruction. It can lead to dehydration. Because you burn such massive amounts of calories when you have dystonia, it can delay growth and development, and obviously contribute, if not cause, its own level of disability. When we think about how to treat dystonia, again, common theme, the benzodiazepines work for most of the hyperkinetic movement disorders. Baclofen is also a mainstay of treatment. And then we get into the more obscure medications that only people like Jennifer and myself who treat patients with movement disorders use on a regular basis. So an old medication called trihexyphenidyl, which is very effective. And then a medication called carbidopa-levodopa, which is a combination medication. And you hear the root word dopa in there. It's the precursor of what's called dopamine, which is the movement neurotransmitter. And then, like as you saw from many of the other movement disorders, we often use anticonvulsants to treat dystonia as well. Thank you for your time and attention in my Zoom struggles. And now you're going to hear from Jennifer on what we do for folks when these medications that I talked about are not effective.
Excellent. Thank you, Dr. Coffman. And I'm glad you could be able to get your presentation to work because you had the overview of all the different movement disorders that I'm now going to talk about. So let me see if I can get my screen to share. One sec. Okay. I may also need to leave the room for it to work. Let's see. Are you guys able to see my screen now?
Yes.
Okay, wonderful. So I'm going to talk about the non-pharmacological treatment for movement disorders. And the one thing I wanted to say just as I go ahead and get started is that when talking about non-pharmacologic treatment for any of these movement disorders, as parents of these children, and I'm sure Dr. Coffman would agree, I would be remiss if I didn't talk about how physical, occupational, and speech therapy are the biggest non-pharmacologic treatment for movement disorders, especially when we're talking about children with spasticity, dystonia, and chorea. They play such a huge role, and therapists are our largest help in maintaining mobility and helping with these children gain function. So it's just something I wanted to mention, especially as I know kind of across the globe, we've had a lot of limitations in therapy with the pandemic. So hopefully that will be improving for everyone soon. But I'm going to talk mainly today about 3 relatively common non-pharmacological treatments for movement disorders as it relates to children with SCN2A. And those are botulinum toxin injections, intrathecal baclofen pumps, and deep brain stimulation. There are some other procedural treatments we can do, including things like phenol blocks and selective dorsal rhizotomies. However, the indications for those typically occur with more severe spasticity alone, which is not typically common in this disorder, so I didn't touch on those as much. The reason we typically consider these treatments, the number one is when the medications alone do not work. Dr. Coffman did a wonderful job talking about the medications for each group, and benzodiazepines and anticonvulsants are definitely our mainstays. I am reluctant to normally consider any of these interventions unless medications have not been effective. However, they can be helpful when you're having a lot of side effects with medications, which can be more common when children are also on multiple anticonvulsants. And if you have a very focal concern, be it a focal tremor, tic, dystonia, or spasticity that's really located to one part of the body. So I'm going to start off by talking about botulinum toxin injections. This is probably the least invasive treatment I'm going to talk about. It's a treatment used for dystonia, spasticity, and tics. It can also be used in Korea, though is not commonly, and the effectiveness of it in Korea is somewhat unknown. It's sometimes used for tremor as well, but as Dr. Coffman pointed out, tremor, a very big part of understanding its treatment is knowing where it is coming from. And there are certain types of tremor that benefit from botulinum toxin injections and one that do not. What botulinum toxin injections involve is injection of a botulinum toxin. I think the most common one we can all think of is Botox. That is injected directly into the muscle that is affected by the dystonia, spasticity, or is over triggering, causing the tics or tremor. It is a very focal treatment. So in patients with any sort of dystonia or spasticity affecting the entire body, we don't often use it because you would have to do injections throughout the entire body. However, it is relatively minimally invasive. It's done typically without sedation. So it's just an injection similar to receiving a vaccine. It can be done by landmark, so just knowing where the muscle location is. That's more common for muscles like the biceps and triceps. For other muscles, we use Emg Guidance, which is what the picture here is, a little Emg machine, and we use a thin flexible needle where we can hear when we're in the muscle based on the electrical sound, as well as it can be done by ultrasound guidance. And I think a lot of people are familiar with that, as our colleagues in ear, nose, and throat often do Botox injections to the salivary glands to help with drooling. And they do that by ultrasound and guidance. We can do it for the muscles as well. Botulinum toxin injections are often used in conjunction with medication. So if your child is on Baclofen or Artane and is having a good response, but you're noticing one thing they're really struggling with is either wrist flexion or wrist extension, we'll often consider doing those injections to just those specific muscles. It also is a temporary treatment. So it works by affecting acetylcholine at the muscle. And the problem is the muscle then reinnervates in response to the toxin in about 8 to 12 to 16 weeks, depending on the patient. So in order to maintain the response, many people require repeat injections every 3 to 4 months. It works in conjunction only with doing stretching and range of motion exercises. So injecting the muscle itself does not provide additional range of motion in children with spasticity and dystonia if it isn't then stretched and worked on strengthening. One thing that we see really commonly in children with SCN2A is the Epistatonic Posturing that you can see with dystonia, which I think a couple of you have already referenced in the chat, and that can be some of the severe arching. Always important to rule out seizures with any sort of abnormal posturing, but botulinum toxin injections can be very beneficial if done to the neck and paraspinal muscles, the muscles along both sides of the spine, in order to decrease that posturing, which can make it difficult for these children to be in car seats, sit in a chair, or even fall asleep, rest comfortably at night. Those injections do typically require EMG guidance to figure out which muscles are overactive. And I have a video of those. I'm hoping these are going to work. So this is a patient with Epistatonic Posturing. And then that's just sitting on the floor, how he has that posturing. And then after injections, he's able to lay comfortably on the table without that posturing. The next intervention I'm going to talk about is intrathecal Baclofen pumps. These are a treatment for spasticity and dystonia. I have seen them occasionally used in children with myoclonus without substantial response. Botulinum toxin injections are also not typically very beneficial for myoclonus, unfortunately. What it allows is, as Dr. Coffman was discussing Baclofen and that it works on GABA. So in order for Baclofen to be effective, it needs to be in the cerebrospinal fluid. That's where it has the receptors that are needed for the medication to be effective are. However, for oral medication to be effective, it has to cross the blood-brain barrier. And there's very limited concentration you can get from giving either oral or G-tube Baclofen into the and getting it to the spinal cord where it needs to be. Intrathecal Baclofen pumps allow us to bypass that by delivering medication directly to the spinal cord. So it's a surgical intervention in which a mechanical pump that's about the size of a deck of cards is placed underneath the skin of the abdomen and connected to a catheter that is threaded up the spine. That allows the medication to be delivered and pumped through the pump continuously up to the spine where it can be most effective. We can then use much smaller doses of Baclofen in terms of the general milligrams you're using, but it increases to a higher dose in the spinal cord versus what you would get from doing oral Baclofen. The effect of intrathecal Baclofen pumps, though, is very dependent on the level where the catheter is placed. So we place it at different levels, our neurosurgery colleagues do, based on where the child is having symptoms. If it's just in the legs, we can typically place it in the thoracic spine, the lower thoracic. For children with issues in the arms or with generalized dystonia, it often requires placement in the cervical spine. It is the procedure of placing the catheter, they actually just make a small incision at the lower back and are able to thread it up. It is complicated if the child already has undergone a spinal fusion, though. That can be where this is typically more difficult. One great thing about intrathecal Baclofen pumps, though, is in most countries, including America, you can often do a trial dose. And in fact, insurance will mandate it often here in the States, where a small dose of intrathecal Baclofen is given via lumbar puncture. And we do serial examinations over 2, 4, 6 hours. Some places even do 24 hours to assess the response and if it improves a child's spasticity or dystonic posturing over that time frame. So that way you can see if your child would have a response before proceeding with this surgical intervention. Once the pump is placed, then the dose is gradually titrated to optimize benefits. The pump itself is refilled through needle access through the skin. It's a sterile procedure that's performed typically in an office without sedation, occasionally with some topical anesthetics such as lidocaine cream over the site, though for the majority of our patients, they don't actually find it very painful. It's performed based on the amount of the dose of Baclofen that's needed in the intrathecal space. For most of our patients, we find it's performed about every 6 to 12 weeks. The manufacturer recommends it's performed at least every 6 months. One thing with an intrathecal Baclofen pump is this is a surgical intervention where if there's a malfunction or if you were to fail to refill it, it can cause acute Baclofen withdrawal, which is an emergency situation. So anybody who's considering one of these, we tell all of our patients with them, it doesn't limit you and your child from traveling, anything like that, but you need to be aware where the nearest children's hospital is in relation to where you're traveling. So if there was a malfunction, you were concerned about Baclofen withdrawal, you would be able to seek the emergency care. The pumps themselves will beep if there's any sort of malfunction. So we say, if your child starts beeping, then you need to immediately head to the emergency room. I'm here in Southern California, and I would say we see about 2 patients a year from out of state who the pump just starts beeping at Disneyland, and then they end up having to come in to see us. So it's just something where if you live 300 miles away in the remote Alaskan wilderness, this is not an intervention we typically recommend. And the last thing I'm going to talk about is deep brain stimulation. This is a treatment predominantly for dystonia. It's also used for specific types of tremor, predominantly essential tremor, also used for tics and chorea. It is FDA approved for dystonia and tremor and used off-label for both tics and chorea. It's also recently approved for focal seizures. All of these approvals are in adults, but they've been used off-label in pediatrics for quite some time. For dystonia, we've been using it for many years. And this is an intervention that my practice does a fair amount of for very severe dystonia. I do always warn parents it is not at all effective for spasticity, which is unfortunate. Intrathecal Baclofen is your best bet for spasticity and that disorder of kind of increased tone. But deep brain stimulation is used worldwide for adults with Parkinson's. That's where the majority of these procedures are done, which I mentioned because if you're considering this procedure, a lot of patients end up actually seeing adult neurosurgeons for it, even as pediatric patients. And that's because adult neurosurgeons are very proficient at this procedure. Deep brain stimulation involves the placement of electrodes into the deep structures of the brain, so the globus pallidus internus, which Dr. Coffman talked about, as well as into areas of the thalamus to try to disrupt the motor pathways that are causing dystonia, tremor, tics, or chorea. We do not know exactly how it works. We have a lot of theories and are doing a lot of research to try to figure that out. But by sending electricity to the brain, we can actually disrupt some of the abnormal signaling, we believe, as well as propagate the beneficial signals. So what it looks like is it's a multi-stage surgical intervention where 2 to 4 leads are placed in the deep structures of the brain using image-guided targeting. So that's based off of MRI images that are done of the patient and then combined with neurosurgical planning based on either a frame or utilization of robotics. That's typically the first stage surgery. In adults, they do that while the patient is awake under local anesthesia. They can then test the electrodes and stimulation with the patient awake in the operating room to assess response. In pediatrics, as I'm sure all of you as parents can imagine, the idea of having a child awake in the operating room while we operate on their brain is a little concerning. It certainly has been done with some children who are cooperative, but particularly in patients such as yours who have seizures and have a lot of movement disorders, we can't have them awake in the operating room safely. So we typically do it under general anesthesia in known targets. The patients then come back for a second surgery where the leads that were implanted in their brain are connected to batteries that are placed either in the chest or in the abdomen. And then those are programmed to allow delivery of stimulation. This is a procedure that also requires regular follow-up, extensive follow-up with somebody who is familiar with the deep brain stimulation programming to maximize effect. In our practice, we see patients who undergo this about every 2 to 4 weeks for the first 6 months, and then every 3 to 6 months for the remainder of their lifetime, or for us until we transition them to one of our adult providers. Our office, as well as there's some others around the country, do a pre-stage 1, which is similar to what our colleagues in epilepsy do, where there is placement of depth electrodes in possible targets for deep brain stimulation to test for optimal location for permanent electrodes and try to figure out where the misfiring signals are coming from. And then I have video of this as well. We'll see if this will work. So this is a patient before deep brain stimulation, and she's trying to hold both arms out in front of her and has significant dystonia of the neck and of her hands. You can see the posturing. And then after surgery, she's going to do the same thing. And one thing with deep brain stimulation, it is not curative. You can see she still has some posturing of the upper extremities, but substantial improvement in terms of the neck posturing and overall posturing. As Dr. Coffman talked about, one of the biggest issues with dystonia and chorea is this constant movement can be really detrimental in terms of calories and nutrition and cause a lot of issues with growth. So we always tell patients you can tell deep brain stimulation is working when the patients start gaining weight is a huge benefit because those extra movements have decreased. And that's it. So let me stop sharing.
Thank you both so much for this great talk. I know that there are a lot of questions, but before we start the questions, I do want to just warn the parents or just make the statement that Jennifer and Dr. Coffman are not your treating providers. So the questions should be directed in a general sense because every case is very different, as you know, and the liability purposes of answering your direct questions is not, direct your care. So just be aware of that. And we can go ahead and start with questions. Again, please introduce yourself, give a little background of where your child is in terms of symptoms, what you've tried, and just go ahead and we'll direct the questions one by one. If you want to help me, Sean, go ahead.
Sure, I guess I'll start off, everybody. My daughter Harper is 4 years old. She does have chorea. We're not actively treating the chorea at this moment, although she is on various benzos to treat her epilepsy. We've considered kind of pursuing it, but I guess our concerns were always we didn't want to monkey with our seizure control when we had it good. Maybe can you give any sense of how effective the chorea medications are and whether they play nice with epilepsy medications?
So I'll take a stab at it. When it comes to treating chorea, there's never been any clear head to head. This is what works best. When it comes to the different medications that we use to treat chorea, the ones that I mentioned, things like amantadine, tetrabenazine, do not worsen epilepsy and should not be a problem. What I do as part of my practice, every single patient that I see, is if I'm adding a new medication, I run the patient's current medication regimen along with whatever medication I'm considering adding through a pharmacology interaction algorithm to make sure that I'm not going to run into any interaction because interactions don't. It can be that this medication slows the metabolism of another medication. So they can compete in more than just one way. So anytime you're considering adding something else, ask about, have we made sure that they don't interact in any way? That's my take on it.
Thank you.
Does anyone want to raise their hand? You can be the next one.
Go ahead, Jacqueline.
Hi. So my daughter is not diagnosed with any movement disorders as of now. She does have repetitive movement, like mouth open and close all day long. Like she never closes her mouth and she's always constantly chewing. And then sometimes she will arch herself, not as violently as what I saw in the videos that you played. But I guess my question is, who would our neurologist be the one to diagnose this, or do we have to see a movement disorder specialist? Is there somebody else? Like, how would we confirm that she does or does not have one of these.
I can take that one. So in an optimal world, hopefully your treating pediatric neurologist might be able to diagnose this. I will say, as Dr. Coffman alluded to, some of these disorders are relatively specialized. So chorea and dystonia are movement disorders that most pediatric neurologists will diagnose, but are rather uncomfortable with some of the medications we utilize to treat. Especially tetrabenazine, trihexylphenidol are not medications that they're used to utilizing. And with children who are on lots of medications, we want to make sure, again, that there aren't any of these interactions. So I typically recommend you start with your primary neurologist, and then if they don't know, ask them about a pediatric movement disorder specialist. There are unfortunately not very many of us around the country, and you may be doing either a Zoom visit with someone far away, or your pediatric neurologist consults one of us more often than not, or we have a fair amount of our patients in California come from a fair distance away. And I wish that we had a better answer than that, but I always say start with your primary neurologist, get an idea of what their comfort level is. And then we're always, in my office, happy to speak to neurologists with questions or to parents, and can do, the one benefit of this pandemic is we can do Zoom visits right now out of state often if needed. But your primary neurologist is always your starting off point.
And I would add one thing to what Jennifer said. You know, with the advancement in technology over the course of the last 20 years, and being able to capture all of these things on video, a number of the consults that I get from people that are not in the Kansas City metro area are physicians that say, hey, a patient of mine has these abnormal, so you can tell me what you think it is on how I should try to treat it. So use your technology, your digital technology, to capture the things in question on video, because it may be that know what it is, but can say, you know what, let me get permission from you to share this with some other people, and send the videos. And we get consults like that. I get consults like that all the time. And it's incredibly helpful, since there are so few of us around the country, to be able to help local neurologists and families just by saying, it's this, it's that, and take a stab by trying to treat it this way.
Thank you for that. I will add to what Jennifer had to say about the consults, because we did talk about this prior to this talk, about the capability of consulting even internationally. So for you, you guys who are out there, outside the US, there is a possibility to consult with movement specialists like them. More specifically, Jennifer, because she got the green light with certain countries. And I know Dr. Coffman has been working on that too.
The other thing I would advise is, if you're at a loss for who to see, talking to your primary neurologist. But if not, you can sometimes look and see if there's a movement disorder specialist more local to you. And if people need recommendations, I think this is so wonderful to have the family group, because people have seen wonderful providers you can recommend, and we're happy to recommend local ones as well. We know, again, it's a pretty small world of pediatric movement disorders, so we know most of our colleagues even across the globe.
Christine's hand is up. Go ahead, Christine.
Hi, I'm Christine. My son Anthony, he has epilepsy. He was just recently diagnosed with dystonia. My question is, what are the odds of a seizure and a dystonic episode happening simultaneously?
Okay, so the odds are not high. Okay, what can happen, okay, is that a seizure, because of the nature of seizure and the level of physical exhaustion that many people get as a result of seizure, could then trigger a dystonic episode after the seizure is over. Okay, so that we see fairly commonly. We don't usually see the other way around, where dystonia causes seizure, and it's because of sort of where they arise in the brain. Seizures come from the cortex of the brain, whereas dystonia comes from the basal ganglia. So now you can have enough, if you have enough dystonia that you end up with sleep disruption or dehydration or something like that, that could precipitate a seizure. But a brief episode of dystonia should not cause seizure. But
Did we lose him again?
Yeah, I think.
no, I'm here.
Froze for quite a while. If you want to repeat the last thing you said.
What was the last thing you heard?
That
I just want to clarify, you can have a seizure first and then a dystonic episode, but it doesn't typically happen the other way around. Is that correct?
That is correct.
Okay. Thank you very much. How do I lower my hand?
Anyone else? I do have a question that came from a family in Europe that asked about a type of movement that happens in the mouth with like a mouth stiffening and then leading to forward bending. Have you seen that type of dystonia before?
I have. I would say it's less common to see it kind of in that pattern of it's clearly begins with the mouth. Most commonly, we see it kind of in conjunction. It's the orofacial dyskinesias that Dr. Coffman was speaking about before. And then we see those occur in conjunction with the arching, but I have certainly seen it. Another thing I'll say, talking about the dystonia versus seizures, they are incredibly difficult to differentiate for most people. If you show up in an emergency department, they will probably always assume it is a seizure. And that's fine because luckily they're both treated with benzodiazepines. But that's just something kind of to be aware of, is even with videos, a lot of times we say, let's rule out that it's a seizure with an EEG before we call it a dyskinesia or dystonia.
Leah, see your hand up.
Oh, thanks. So Dr. Coffman, I've talked to you about this in the past, and we were scheduled to come out to see Dr. Coffman, and then my son's seizures just got out of control, and we had to deal with that first. But my son has always had these episodes of stiffening in the upper body. They look like seizures, except for they last 25 minutes. So they're not seizures. We know that. They don't always show up on EEG as a seizure. Sometimes they do, but not usually. Hands and feet get soaking wet. Any tremors. Eyes are fully dilated all the way to black, and they usually are open really, really big, like he's scared. Is that a movement disorder, or is that an autonomic storm, or are they pretty much the same thing?
Okay, so there is an entity that I didn't speak about at all, that can occur, and we call it, scientifically, we now call it paroxysmal, so sudden onset, sympathetic, meaning your sympathetic nervous system, which is your fight or flight system, hyperactivity, so PSH, and PSH a variant of PSH is PSH with dystonia. So what happens in this condition is that you get a flood of output from your autonomic nervous system, which is why you get sweaty, hot, agitated, pupils, as you said, doesn't show up as EEG. So PSH with dystonia is a very common thing in my world of taking care of complex patients. And think about PSH is, unlike seizure and unlike dystonia, paroxysmal sympathetic hyperactivity usually occurs around the same time every day, give or take. So, and it's because for the most part, it comes from abnormalities within the hypothalamus, and the hypothalamus is involved in your circadian rhythms. So one of the key things when I'm evaluating with anybody with episodes like you described is timing. So if the timing is pretty consistent throughout the day, that's when you go down the path of, is this paroxysmal sympathetic hyperactivity with dystonia? And then the treatment for that condition is remarkably different than anything we talked about, because what you have to do there is better regulate the autonomic nervous system so it doesn't surge. So we don't use any of the medications for the most part that we talked about for treating other movement problems.
Okay, that's really helpful. And it does happen every single time. It happens when he's waking from a nap, not waking from the morning, not like from the sleep at night, but only from a nap in the afternoon. It's like clockwork. It doesn't happen every day, but when he does happen, they're always from waking from a nap. Thank you.
We could refer to his prior talk that he's done extensively talked about the dysautonomia and PSH, because you do go into that into detail into treatments, and it does correlate with this, but it's a whole separate talk.
Go ahead, Christine.
Talking about the autonomic function, nervous system, is it possible if you have damage to the vagus nerve that can cause that to be disrupted?
So so when we think about autonomic dysfunction, usually in the patients that I've seen, I treat, the problem that leads to autonomic dysfunction is more central. So it's abnormal brain activity. The system is that it's paired, right? So we have sort of redundant circuits built in. So we have two vagus nerves, one on the left, one on the right. I have not heard of anybody with autonomic dysfunction nor of a vagal problem in the time that I've been doing this.
Okay. Thank you.
I have one more quick one if there are no other hands up. I guess some of the videos of dystonia, Harper often throws her head back, in a similar fashion, but it's usually, when we try to put her in a chair and it seems like in response to an action that she doesn't like. I guess when you're looking at videos, how do you differentiate between, a kiddo that can't communicate, telling you that they don't want to do something versus something that looks like dystonia?
So it varies, and I think I'm glad you brought this up, Sean, because another important, obviously, mimicker of that posturing is severe reflux can very much cause that same kind of arching that we can see. I think it depends more on if you can correlate it to if the child is comfortable otherwise and having that. The problem is dystonia sometimes can be triggered by pressure on certain parts of the muscles. So for a lot of children, we see it when they're in a seated position, such as a wheelchair or a car seat. When I have that question, a lot of times we'll even do Emg guidance and listen to the Emg when it's happening to see if it's kind of the voluntary muscles you'd expect or more of the antagonist or agonistic muscles that you're not expecting. But it can be very, very difficult. And the thing with treatment is we typically treat based on how much it's interfering with activities of daily living and their life. So if it's just, she hates sitting in this one high chair car seat, so we just don't use it, then I would say the answer is if we can avoid the triggers, then you don't have to go down that road. But if you're noticing it continuously, then it becomes something where I would recommend being examination and possible treatment.
So the one thing I will add to that is dystonia is a movement disorder that strong emotion can trigger because of the relationship between the motor system and emotional control. So if you notice that, you know, it's always when with a high level of frustration or irritation that you see it versus a different position, again, that's those clues that we use to say, is it dystonia or is it not, is what's the situation?
Thank you.
The question for both of you in relation to this topic is, I mean, what are other triggers that you typically recommend parents to watch out for? I know we've talked about, Jennifer, in clinic, about heat intolerance, being tired, pain. Like, how do you go about telling families like things to watch out for and check off their list?
Constipation, number one, constipation. Okay, the number of patients that Jennifer and I and our colleagues in the world of movement disorders see who have terrible problems with dystonia that isn't responding to treatment is constipation. Because constipation, when it comes to dystonia, is a double-edged sword, okay? Constipation can lead to dystonia. Dystonia can lead to constipation, right? So my practice when it comes to when is constipation, when is bowel control appropriate, is the following metric: 2 to 3 soft, easy to pass bowel movements every single day. If you're not at that level, you are not effectively cleaning out the colon. 2 to 3 soft, easy to pass bowel movements every single day. If you're not there, you need to get there.
That's a great tip, because most people assume that you're having a daily one and that means you're not constipated, but yeah.
The other thing, and Mary, I know we've talked about this, is once you have a child with dystonia, you realize that anytime they have any sort of pain or illness, the dystonia will always get worse. Almost always. I do have a small number of patients who actually get flaccid with illness, but they are the very, very small few. And I let families know that's really kind of your sign that something else is wrong. So if you have a child with dystonia who is all of a sudden getting worse, your first trip is always to call the pediatrician, and we want to see constipation. Dr. Coffman is 100% right. I spend all day talking about it, as well as, is there a urinary tract infection? Is there a pneumonia? Something like that. If there's an underlying trigger, either infection or pain, the dystonia is incredibly difficult to manage. So we always want to kind of use the dystonia as a key sometimes to say something else is going on.
Ear infection is another big one. Ear infection is another big one to really worsen dystonia rapidly.
I have a question. For we talked about a lot of patients with epilepsy and dystonia. Do you see a lot of patients with just autism diagnosis and no epilepsy? And if so, are their presentations different? You know, there's a certain presentation that my son does that no one knows why he does it. Sometimes it's about constipation, but not consistently. So just wondered.
Yeah, so my background is a bit different. I'm a neurodevelopmental disabilities neurologist who then fell in love with treating movement disorders. So I see many kids with autism and developmental disabilities that are not related to movement disorders. When it comes to children with autism and the differences they have in movement and behavior, it is those are the videos that I start at the feet. I watch, and then I go up to the hips, and then I go up to the rest of the body. And I do it stepwise so I can figure out what the phenomenology is. Because you pick up on all these little clues when you look at people segment by segment to really figure out have autism from whatever cause and do things that are abnormal and atypical for them. That's the way to sort it out.
Thank you.
Did you catch the first part, Carla? Because I know he froze.
A little bit.
Okay. Jennifer, I have a question about DBS. If no one has a question, what's the earliest age that you would consider DBS? I know we talked about this too, and you said it's not FDA approved for our children yet, but what's the youngest that you've put a DBS in the patient?
The youngest my practice has done was age 5. I believe the youngest is below the age of actually 12 months. That was done in the UK. The general neurosurgical opinion is, and I've been talking to our pediatric neurosurgery colleagues about this, is at least age 3 is really the goal, if at all possible, just because then you don't have to worry as much about skull shift. Deep brain stimulation for children has some, the risks associated with it are very different. In adults, when you're putting wires in the brain, we worry a lot about stroke and bleeding risks. In children, we worry about infection. And with younger children, that also becomes a concern for us as possible infection, as well as making sure they have enough fat to kind of slide the batteries underneath and that there's room for growth. The batteries, and I did not mention this, for deep brain stimulation have to be replaced about every 15 years. Baclofen pumps have to be replaced about every 7 years. Both of those are actually pretty easy surgeries, even if the device is placed when you're a child, because it's just at kind of the submuscular, or depending on where they're placed, can be sub-fat pocket. But we do try to wait till the child is a bit older, also because the situations when they're placed when younger are typically looking at palliative situations, because we can't get the same level of response. So for deep brain stimulation testing in children, we like to be able to see, does it improve the dystonia while testing? Do they feel a response? And you guys are all parents, so you know, if you ask a 1-year-old how they feel, you don't get any response at all, honestly, because it depends. Are they crying, hungry? Do they want to be held by mom? So if at all possible, we try to wait till at least age 5, but there's definitely a lot of discussions about doing it sooner. And it has been done in other countries as well.
And at our institution, we do not implant anyone younger than 7 years of age at our institution.
And Can you tell us again how that would help seizures? What's the mechanism of that? Or it's
The
unknown.
mechanism for deep brain stimulation is completely unknown, is the problem. So I can't give you an exact clear response. And I do want to say, I do not know how young they have done an implantation for seizures for deep brain stimulation. The FDA approval for DBS for focals, and again, it's focal seizures only. It was approved in adults about 2 to 3 years ago now, so it is exceptionally recent. We have actually seen it as an incidental finding, and a couple of our patients have had decreased seizure frequency with deep brain stimulation, but they were not implanted for that purpose. Again, the idea is the electrical stimulation that you're sending disrupts the hyperexcitability of the neurons potentially, but I don't want to tell you that there's a clear mechanism of action because we don't know it yet.
Thank you.
So to follow up on that, the target site is completely different. So when we're talking about using deep brain stimulation to treat dystonia, the FDA approved target site is the globus pallidus within the basal ganglia. For epilepsy, it is one of the subnuclei of a structure called the thalamus. So it's a completely different anatomic location with different connections to other regions of the brain. So as Jennifer said, you would not expect DBS for dystonia to improve seizure control, and it's because you're talking about completely different anatomy.
No other questions. I have a lot of questions. I'll keep shooting them at you. In terms of benzos to treat movement disorders in general, can you talk about the different types of benzos and what is preferred? Because there's short acting versus long acting. So what's the preferred one?
I think we'll probably both have opinions on this. So Jennifer, go ahead first, and then I'll follow up.
Yeah, so I would say my preferred one is typically clonazepam because it is a little bit of a longer acting benzodiazepine. It's also, clonazepam is not available in an IV formulation. So as much as we can, we sometimes try to keep our patients IV benzodiazepine naive because that needs to be your rescue medication if you end up in the hospital with either status epilepticus or status dystonicus. Those are typically triggered by something underlying. Now you can use things like a Versed, which is midazolam, drip in those situations, which is only available IV, though there is an intranasal form now, I guess. But in typical case, I try to use clonazepam. I definitely have patients on diazepam as well. But I would agree, I think it's a contentious point among movement disorders. So Dr. Coffman, what about you?
So yeah, this is one of those circumstances where two different people who practice the same thing have the exact same opinion. So clonazepam is always our first line. And part of the reason is delivery, right? So clonazepam comes in one of the most pediatric friendly delivery mechanisms. It comes in an orally disintegrating tablet, which is incredibly G-tube friendly. So you don't have to worry about refrigerating liquids. It's easy to travel with. And then diazepam is the other. We don't typically use lorazepam, and we definitely do not use the shorter acting things that are mostly used for anxiety, like Xanax, because they simply wouldn't work.
I guess when you're in like a dire state, such as status dystonic is, IV is the only treatment really at that point that will abort the episode, right? Or is there no abortive really treatment?
No, you're right. IV benzodiazepines are the mainstay of treatment for status dystonicus. Unlike status epilepticus, where there are numerous agents to try in various different orders to try them, because unlike epilepsy, where we know really what the pathophysiology is, we still don't know at its core what causes the brain to generate dystonic movement. So what firing abnormalities are occurring in the basal ganglia that really lead to dystonia, and what all regions of the brain generate dystonia. So we are unfortunately decades behind our colleagues in epilepsy in terms of being able to say, this is the right way to treat a status dystonicus or a dystonic storm, because we just don't know enough of the basic science yet.
I know a lot of families here do not know what that is. If you can just briefly maybe tell us what the status dystonicus or dystonic storm is for educational purposes, so that a family would know when to take their child to the ER, that'd be great.
So status dystonicus is just like status epilepticus. So it's unlike a status epilepticus where it's a seizure that doesn't stop. This is a dystonia that doesn't stop. And just like status epilepticus, it can be life-threatening. So if you are having a prolonged episode of dystonia and you are seeing your child not able to eat, not able to drink, not able to get comfortable, and he or she is stuck and locked in place, it is the same level of emergency as status epilepticus, because if it doesn't resolve, then things like dehydration and muscle breakdown leading to kidney injury are the cascade. So it's rare, right? In terms of the number of times in the 20 years that I've been doing this that I've had to treat patients with status dystonicus, it's exceptionally rare compared to status epilepticus. But it can be as devastating, if not treated successfully, as status epilepticus.
Thank you.
We have a question that came in. Can untreated PSH with dystonia cause damage long-term?
No, but it's miserable to watch, and it's miserable to have your kid go through. But thankfully, because it's such a common phenomenon in the brain injury literature, we know that thankfully it doesn't cause any long-term problem, but it's miserable.
Thank you.
And one thing I'll mention is we've been talking a lot about dystonia, and when dystonia is severe, just a big thing to be aware of with any child with dystonia or chorea is especially watching nutrition, like Dr. Coffman mentioned about the severe calorie deficits we can see. We're very big proponents of, if nutrition is a concern, early G-tube implantation for these children, because especially with growth, you will not be able to get enough oral intake to get enough calories in them, unfortunately, for a lot of these kids, unless we can get very good management of their dystonia and chorea. And chorea in particular is very difficult to get good management of. So it's just something I always point out, is if you don't see gastroenterology, that may be something to consider kind of being more aggressive with. Because if not, if your child gets sick, the dystonia gets worse, we can see infection can be a very big concern for these children because they just have no reserves.
For Harper with the chorea, just to follow up on that, she's also on the ketogenic diet to battle epilepsy. Are there any kind of tips or tricks to help with nutrition? I mean, the diet in itself can make it challenging to meet, nutritional goals, but then with the chorea on top of it, it makes it hard as well. I guess, how do you typically handle those? Is it just really pushing calories, or are there different foods that, are better or worse?
We
Good.
typically really push calories from my experience for the ketogenic diet families. I'm working with the dietitians who are managing it.
Yeah, the key thing is exactly what Jennifer just said. When it comes to the best way to maximize calorie delivery in anybody that's on keto, it's your dietitians. I mean, expert ketogenic dietitians are worth my weight in gold. They're just phenomenal human beings. That's who you reach out for.
Thank you.
We have a question from Victoria.
Well, it's gonna depend on what, Tom says.
If you can mute, thank you. Victoria.
Hi. So my son is 4. I keep on thinking he's 3. He's 4. He just turned 4 in June, and we recently noticed a change with his bowel movements, and sometimes he has them in the middle of the night. But then we've been working on different medications with that, and he seems to also have. He hasn't been diagnosed with any of these different tremors or tics or anything. And he follows neurology just to make sure he doesn't have seizures. He's loss of function, so he hasn't had any seizures. So we're currently trying to look into, maybe doing an EEG study overnight, and things like that. But I'm also curious with some of these movement disorders if they can impact the, the movement of his food. He doesn't take. He eats through, he doesn't have a feeding tube or anything. He eats purees, and we see a feeding specialist to work on eating. But I was just curious if there's, I think there was a question earlier about what studies we should be asking for. He's seen at CHOP, and so I'm trying to figure out whether we need to look into some of the things that were raised today and how we do that. Sorry if that didn't make sense.
No, it made absolute sense. To boil the question down, can movement problems affect the way you move food through your gut? 100%, absolutely. And interestingly, and very timely that you asked that question, because just today I was notified of a new research grant proposal from the National Institutes of Neurologic Diseases and Stroke that is actually looking at this exact same question in terms of trying to identify and intervene with gastrointestinal symptoms in children with neurodevelopmental disorders, regardless of what kind of disorder it is. So yeah, your question is all the way up to the folks at the NIH, because they are wanting to understand why our patients with neurodevelopmental disorders, whether it be autism, epilepsy, dystonia, why their guts don't work right. Because this is now recognized as a real big problem in our community.
Yeah, he takes Senna right now, and he seems to go every other day, but his feeding doctor wants him to go every day. So I don't know. He seems to just maybe have delayed. I suspect maybe he has delayed emptying or something. He eats okay, or he's small. We've been watching his weight ever since he was little, because he still doesn't eat well. So, but to keep him off of feeding tube, we have been working really hard on eating. So he's learning how to chew. But I don't know with his bowel movements, what we can do for that.
Yeah, I would ask his feeding doctor, because the thing with feeding is you got to deal with both ends of it, right? It's got to go in and it's got to come out. So anybody who's managing feeding should be very on top of managing the bowel issues as well.
I have a question regarding constipation. Do you recommend certain things for the constipation, or do you normally refer them to GI? And if you do refer them to GI, is there a specific type of GI that we should ask for?
Okay, so all of us pediatric neurologists had to do 2 years of pediatrics residency before we did child neurology, right? And a big part of managing kids overall is gut and constipation. So I really, when it comes to what I recommend, I take it just as individually as I do when it comes to managing the dystonia. It's what's the right situation and choice for that child, especially with whatever other meds he or she is on. So that's the way I approach it. There are, you talked about rare, there are even more rare than pediatric movement disorder experts are what are called GI motility experts. So these are basically GI doctors who think about the neurology of the intestinal tract and how to manage it, because they're, you know, the enteric nervous system, so the nervous system within the gut, has incredible numbers of neurons. So if you're having problems with GI symptoms and you're seeing a GI person and you're not making any progress, the next question is there a motility expert anywhere near me or within a reasonable distance that I could see? Because they are, like Jennifer and I, the movement people of the gut.
Yep, and I'll second what Dr. Coffman said. If you are seeing GI to manage this, you just want to make sure that all of us, whoever is on the healthcare team for your child, we're all communicating together, because a lot of this can then, if we're adding medications to increase motility, you can end up affecting other medications and response. So we just want to make sure that whoever is managing that takes all that into account. As well, I typically manage constipation to a certain point before I pass it off to my colleagues in GI, and that's typically about 3 medications and we then hand it off.
Thank you both.
Other questions? I do want to talk and ask you both about just the severity of the irritability that we see on our younger newborn population, actually. Like I would say babies up to age 2, that seems to be like a very, very typical presentation and just the biggest struggle in the initial years. And I don't know if you talked about this before, about the gene and SCN2A coming in and taking over, whether that truly is what's happening with, you know, symptom wise, and what is making things better or not, or just a coincidence. I wanted to get your thoughts on that.
So honestly, as I was sitting and hearing you ask the question, I was wondering to myself, you know, what would drive the irritability? Because when we think about the development of motor control, you really don't have voluntary motor control as a newborn. You know, as the nervous system matures, you start to gain voluntary motor control. So it's not a movement problem. If I had to speculate, and this is pure speculation, without any data to back it up, I would suspect that it is an autonomic nervous system problem, because when you are in early life, your brain is really a little bit of cortex in terms of what's working, a little bit of cortex, brainstem, and autonomic nervous system. And given the increased attention to autonomic nervous system dysfunction in the developmental epileptic encephalopathies, including the paper that Ann Berg, Deborah Gabler-Spira, and I just published. It actually just got published and released to the public on Sunday, about the surprisingly high rate of autonomic dysfunction across the developmental epileptic encephalopathies. I would hazard a guess that the irritability is an autonomic nervous system manifestation. May have just given me another research idea. Okay.
Yes, we need it. I mean, as you know, like everyone struggles so much with their newborn, as is, even healthy ones, and the crying, colic, whatever. But add on SCN2A to the picture and seizures and meds, it's like, how do you even deal with all this in a stepwise approach? I mean, with babies, typically they'll always say if they're arching, oh yeah, you got to rule out reflux. It's reflux, looks like reflux. Once that's ruled out, like what's next? So what would you tell our families who are currently, like right now, struggling with a very irritable baby that cries for 12 hours and presents with some arching and they've ruled out reflux? Like what's the next step?
Well, first, and it sounds like I'm a broken record, but get it on video, right? Okay. Because you get it on video, and people like myself and people like Jennifer, we're detectives, right? So you look at the video and you look for clues. What do you see in the video that helps you to understand why this is happening? And if someone says, well, I don't know, then my next thing is be persistent. Well, who might know? Who could we contact if you say you don't know? Yeah, get it on video and be persistent. Those are my two biggest hints.
Thank you so much. I mean, from personal experience, I want to say that we struggled so much in the first 2 years until we got the dystonia diagnosis finally after age 2. But the first 2 years, it was always, oh, it's got to be a medication. It's the felbamate, one of the meds that causes severe irritability. It's probably the high dilantin levels. It's probably, oh, he's just like super low tone and he uses extensor muscles because that's his way of communicating or compensating for whatever low tone he has. So it's just like one thing after another that was wrong until we got the appropriate diagnosis and then got it treated appropriately to get to this day where he's calm and not dystonic at all. So just the biggest struggle is just the initial years and going about it.
Yeah, and that's where I'll second Dr. Coffman. You guys know you're the biggest advocates for your children, but take videos and ask if you're seeing someone locally for them to share the videos if they're not sure. And I see the question in the chat about if dystonia always comes with irritability. It does not, surprisingly. For some children, they will just have the posturing and they will not be irritable or in pain at all. And that's where I say then it becomes more a question of what benefits you get from treating. But unfortunately, especially with the epistatonus, there is typically a lot of irritability.
Yeah, you can have, I'll follow Jennifer's comment, you can have very focal dystonia. So one hand, one arm, one leg. Those are the kids that, we both see in our office because they're, not moving right, and nobody knows why, but they're happily dystonic. In our world, those are the kids that unfortunately often show up before kids like SCN2A kids because of the fact that it's a clear abnormality that doesn't fit the rest of the equation. But when you listen to Mary and her story, you know, these patients, your guys' kids, folks, you know, as you heard from Mary, well, it's got to be this, got to be that, got to be this, got to be that. And that's why get it on video and be persistent, because that's how you prevent bad things from happening, is to not just take, well, I don't know, for an answer.
Thank you. Do we have any other questions? I know it's getting late, so we can start wrapping things up. If not.
I have one last question. It seems that there is a wide range of age of onset with dystonia. You have some of the SCN2A community where it's from birth, and then you look at my son and he went into puberty. Is there an explanation for that? Like, considering we all have the same gene?
So I'll tackle the puberty thing. We know that puberty from a biological standpoint is an incredibly stressful situation on the body, because you have so many things happening at once. Number one, you often have a big growth spurt. Two, you get hormone release that hasn't been there before, and that stresses the system. And then three, what happens in the early part of the teenage years is that you get new activation of brain areas, specifically the prefrontal cortex, so right above the forehead. And this creates the perfect storm of, is it the puberty? Is it the rapid growth? Is it the activation in brain? But it is very, very common for people who have never had dystonia before to start having dystonia in the teenage years, because of those three factors that really throw a wrench into the works.
And then just one follow-up question with that. Is it more likely to resolve once puberty is over, or is this more likely, you know, for the duration of his life?
I've seen it go both ways. And what I tell families is, you know, by the time, so depending on when you start puberty, if you hit puberty at 12, I usually am able to say, you know, by the time we're 15, 16, we'll be able to know what it's going to be like moving on.
Okay.
Because it can go both ways.
All right. Thank you very much.
Then if you think about it the other way around, if the dystonia worsens, is it like an alarm for parents to be aware of precocious puberty, if that's the onset, right? If that's something that we should watch for? Maybe.
I always, so in all of my patients with neurodevelopmental disorders, regardless of cause, worsening of movement, I always ask about any signs of early pubertal development. It's one of the biggest things we think about in my world.
I would completely agree.
Yeah.
Good to know. Thank you. If there are no other questions, we can call it a day. Last thoughts? All right, I think this is it. This concludes our session. And again, we wanted to thank you both, Jennifer and Dr. Coffman, for your time and expertise. And thank you everyone for participating. A great session, and take care. Bye.
Thank you, everyone.
Thank you. Take care.
Thank you.